Hello everyone and welcome back to the channel. When we think about rheumatoid arthritis, we usually think about painful joints, swelling and morning stiffness. But rheumatoid arthritis can affect much more than the joints themselves, and one complication that doesn't always receive enough attention is bone loss and osteoporosis. If you have rheumatoid arthritis, your risk of developing osteoporosis and suffering a fragility fracture can be higher than somebody without inflammatory arthritis. And importantly, this isn't simply because some patients take steroids such as Prednisolone. Rheumatoid arthritis itself can contribute to bone loss. I'm Dr. Naveen Bhadauria, consultant rheumatologist at Pure Rheumatology London, and in today's video, I'm going to explain why rheumatoid arthritis can affect your bones, how inflammation and medication such as steroids contribute to osteoporosis, who should consider having a bone density scan, and most importantly, what you can do to protect your bones. Let's start with the basics. Osteoporosis is a condition in which the strength and structure of bone deteriorate, making bones more vulnerable to fractures. These are sometimes called fragility fractures because they can occur following relatively minor trauma, for example, falling from a standing height. Common sites include the wrist, hip, and spine, and osteoporosis is often described as a silent disease because you generally can't feel your bones becoming thinner. For many people, the first sign of osteoporosis is unfortunately a fracture. So why does rheumatoid arthritis increase the risk? The first reason is inflammation. Rheumatoid arthritis is a systemic inflammatory disease. Although we see the effects very clearly in the joints, inflammatory cytokines circulate throughout the body and can influence the normal process through which bone is constantly being broken down and rebuilt. Our bones aren't static structures. Throughout life, old bone is continually removed by cells called osteoclasts, and new bone is produced by cells called osteoblasts. Normally, these processes remain reasonably balanced, but chronic inflammation can shift that balance towards increased bone breakdown. Inflammatory pathways involved in rheumatoid arthritis can stimulate osteoclast activity, meaning bone is broken down more rapidly. If that continues over time, bone density and bone strength can decrease. So one of the first important messages from this video is rheumatoid arthritis itself can be a risk factor for osteoporosis even if you've never taken steroids. Now let's talk about steroids because this is where the risk can increase further. Medications such as prednisolone can be extremely useful in rheumatology. Sometimes we use them for short periods to rapidly control inflammation while we're waiting for a disease-modifying medication to work. But long-term or repeated exposure to glucocorticoids can have important effects on bone. Steroids can reduce the formation of new bone, increase bone breakdown, affect calcium metabolism, and reduce muscle strength. This combination can significantly increase fracture risk. And steroid-related bone loss can occur relatively quickly, particularly during the first months of treatment. This is why if somebody is likely to remain on glucocorticoids for a prolonged period, we shouldn't wait several years before thinking about their bones. Bone protection should be considered early, but steroids and inflammation aren't the only reasons people with rheumatoid arthritis can develop osteoporosis. Think about what happens when somebody has poorly controlled arthritis. Their joints hurt, so they move less. They may stop walking regularly. They may stop exercising. They lose muscle strength, and because bones respond to mechanical loading, reduced physical activity can contribute to loss of bone strength. Reduced muscle strength can also increase the risk of falling. So you can end up with several factors operating at the same time: inflammation affecting the bone, steroid exposure, reduced activity, muscle weakness, and an increased risk of falls. Then we have all the usual osteoporosis risk factors that can affect anybody. Age is important. Menopause is important because declining estrogen levels accelerate bone loss. A previous fragility fracture significantly increases future fracture risk. Family history, particularly a parental hip fracture, can matter. Low body weight, smoking, and excessive alcohol consumption can also increase risk. And certain other medical conditions and medications may contribute. So when assessing somebody with rheumatoid arthritis, we're not simply asking, do they have osteoporosis? We're really asking, what is this person's overall fracture risk? One tool commonly used to help estimate this is FRAX, which calculates the probability of a major osteoporotic fracture and hip fracture over the following 10 years. Interestingly, rheumatoid arthritis is specifically included as a clinical risk factor within FRAX. We may also arrange a DEXA scan, which measures bone mineral density, usually at the hip and lumbar spine. Patients often ask me, should everybody with rheumatoid arthritis have a DEXA scan? Not necessarily. The decision depends on age, sex, menopausal status, steroid exposure, previous fractures, and other osteoporosis risk fractures. But if somebody has rheumatoid arthritis and additional risk factors, particularly prolonged glucocorticoid treatment, increasing age, previous fragility fracture, or significant other risks, then assessing bone health becomes increasingly important. Now let's talk about vitamin D and calcium. Vitamin D is essential for normal bone health because it helps the body absorb calcium effectively. If you're vitamin D deficient, that should generally be corrected. But I want to emphasize something important. Taking vitamin D doesn't automatically prevent osteoporosis. Vitamin D is part of bone health, but osteoporosis prevention is much broader. Similarly, calcium is important, but that doesn't mean everyone needs to buy calcium supplements. Where possible, adequate calcium should generally come from the diet. Some people may need supplementation depending on dietary intake and individual circumstances, but taking large amounts of calcium unnecessarily isn't the answer to osteoporosis. So what else can you do to protect your bones? Exercise is incredibly important. Weight-bearing activities such as walking, together with resistance or strength training, help maintain both bone and muscle. Strengthening muscle is particularly valuable because stronger muscles improve balance and reduce falls. If your rheumatoid arthritis is making exercise difficult, the solution shouldn't simply be to stop moving. It may mean adapting the exercise, working with a physiotherapist, or getting the inflammatory arthritis under better control so that you can become more active again. And this brings us to something that can sometimes be overlooked. Treating rheumatoid arthritis effectively is itself part of protecting your bones. If we control inflammation, reduce the need for prolonged steroids, improve mobility, and allow somebody to exercise normally again, we're addressing several contributors to osteoporosis at the same time. That's another reason why early and effective treatment of rheumatoid arthritis matters. What happens if we discover that somebody is at high risk of fracture? We have very effective osteoporosis treatments. For many patients, treatment may involve a bisphosphonate such as alendronate or intravenous zoledronic acid. Other patients may be treated with medications such as denosumab. And for people with very high fracture risk or severe osteoporosis, we may consider bone-building treatments such as teriparatide or romosozumab, depending on the clinical circumstances and local treatment criteria. The important point is that osteoporosis is treatable. We don't simply diagnose low bone density and watch it deteriorate. The aim is to reduce the likelihood of fractures, particularly hip and vertebral fractures, which can have a major effect on mobility, independence, and quality of life. And there's one final issue I want to mention. Vertebral fractures can sometimes be missed. Not every spinal fracture causes dramatic acute pain. Some people gradually lose height, develop increasing curvature of the spine, or experience persistent back pain without realizing they've sustained vertebral compression fractures. So if somebody with osteoporosis risk factors develops unexplained height loss or significant new back pain, it's worth considering whether a vertebral fracture could be present. So what are the key messages from today's video? Firstly, rheumatoid arthritis doesn't only affect your joints. Chronic inflammation can also contribute to loss of bone strength. Secondly, long-term or repeated steroid treatment can increase osteoporosis and fracture risk further. Thirdly, your overall risk depends on multiple factors including age, menopause, previous fractures, family history, smoking, body weight, activity levels, and other medical conditions. Fourthly, bone health can be assessed using tools such as FRAX and, when appropriate, a DEXA scan. And finally, there's a great deal we can do to protect your bones. Control rheumatoid arthritis effectively, minimize unnecessary steroid exposure, maintain adequate vitamin D and calcium, exercise, preserve muscle strength, reduce falls risk, and treat osteoporosis when treatment is indicated. If there's one message I'd like you to take away from this video, it's this. If you have rheumatoid arthritis, don't just think about protecting your joints. Think about protecting your bones as well. Osteoporosis is often silent until a fracture occurs, which is exactly why identifying risk before that first fracture is so important. If you found this video useful, please give it a like and subscribe to the channel for more evidence-based videos about rheumatoid arthritis, osteoporosis, autoimmune disease, and modern rheumatology treatments. And let me know in the comments if you'd like me to make a separate video answering the question, Who actually needs a DEXA scan, and how do you understand the results? I think that would be a very useful follow-up, because terms such as T-score, Z-score, and FRAX can be confusing when patients first receive their results. Thank you very much for watching. Take care, and I'll see you in the next video.